As said, I'm Victoria Metaxa, and I'm one of the consultants at King's College Hospital in London, UK. And I do have an interest in hemato-oncology patients, and especially those receiving CAR-T. So I'm going to talk to you a little bit about CAR-T therapy, and very speedily tell you what I think we should all know as intensivists when we're asked to look after these patients. These are my conflict of interest. So CAR-T therapy is a type of adoptive cell therapy, which basically means that we take cells from a patient and then we manipulate them ex vivo and then we return them back to the patient. It's a type of immunotherapy. The whole point is to enhance the immune response of the patient against tumor cells. And immunotherapy and immunomodulation has gained a lot of recognition when targeting solid tumors and especially metastasis, but now it started spreading in hemato-oncological tumors. So what are CAR-T cells? Well, they are genetically engineered cells, you can see in the slide that there are a few generations of them. Why do we need to know that? Well, because depending on the type of CAR-T that we use, their function and, of course, their toxicity differs. So the first generation, you see, they only had an ectodomain and an endodomain, so an extracellular portion and an intracellular portion. They were very basic. They did the job, but they didn't persist long. So they had higher apoptosis, but they didn't have a lot of toxicity. What we do currently have is the second generation. And you can see in the second generation, we have an extracellular portion, which is where the receptor, which includes the antigen recognition domain, lies. So it's where the domain that will recognize the tumor cell is. Then you have a transmembrane domain, and that primarily supports stability, and an intracellular domain where the activation and the facilitation of the transduction happens. Again, this is very important because by adding this co-stimulatory domain, the transmembrane domain, increased the durability of CAR-T cells, but unfortunately, as we'll see later on, it also increased their toxicity. So here you see the whole process, the whole time frame. The time from collection to infusion currently takes 3 to 4 weeks, and I will tell you why this as well is very, very important. So the first step is to take peripheral blood mononuclear cells from the patient with large volume apheresis, and then send them to a manufacturer, to the manufacturer facility. Not every country has manufacturer facilities, and for example, still in the UK, we do send our cells to other countries, and that, of course, increases the time frame and the timeline for this procedure. So then you incubate the T cells with a viral vector. You insert mRNA, then you reverse transcribe that to DNA, and then you do have your T cell. Those two T cells, of course, need to be expanded, and they continue to expand and multiply for several days until and after that, then the finished product gets shipped back to the hospital and gets transfused to the patient. This is very, very important, and it takes, as we said, up to a month, sometimes even more. It's very important because the patients that will receive T cells are patients that are really sick. They have already received at least 2 lines of other therapy, and without the CAR-T cells, their life expectancy at maximum is about 6 months. So they are patients that without this therapy are end-of-life patients, and somehow they need to hold on from the decision to give them the T cells to the actual infusion. And that sometimes can be tricky. So how do these CARs function? So basically, when they see a malignant cell, they recognize it, and they attach themselves to it, and then they activate. They not only activate, but they start to expand and proliferate. As this happens, then secretion of cytokines, and specifically TNA factor and interleukin 1 and 2 and 6 is what is secreted. So this is how they work, but also this is how their toxicity ensures. So other cells are activated as well, and you see in that slide the macrophages, and then more cytokines, and then you get all the symptoms that you sometimes get from CAR T cells. And this is how, and this is why, the most common of the toxicities after CAR T cell therapy, which is the cytokine release syndrome, CRS. That's how that is the explanation, the pathophysiology behind it. So the cytokine release syndrome is quite frequent. Sometimes from 60 to up to 90% of all patients that receive the cells will get any kind of any grade of CRS, and up to 20% of them, about a fifth of them, will develop grade 3 or higher CRS. Here you see the categories of CRS. This is a consensus from the American Society of Blood and Marrow Transplantation that came to replace all the various other gradings that we had, and it's very useful now because we all have a common language. So you see that there are 4 grades depending on how sick the patient is, depending on the hypertension, the degree of hypertension, and or hypoxia. Fever is a standard, a gold standard. So to have CRS, of course, you need to have fever. So as intensivists, what we care about, though, is the fact that this grading, yes, has unified things, but it hasn't 100% resolved them. And this is what I mean. Look at the grading 2 and 3 of hypoxia. And for a patient to have grade 2 CRS, they need to have low flow nasal cannula oxygen. And by low flow, they mean oxygen delivered less than 6 liters per minute, and high flow more than 6 liters per minute. I hope you agree with me that this is quite arbitrary. So sometimes some institutions, we never use nasal cannula for more than 3 liters, for example. And what we do use a lot is high flow nasal cannula oxygen, which doesn't really feature in this grading. What is also more important is the grade 3. So for a patient to have grade 3 means they are hypotensive, fluid haven't worked, and they need now a vasopressor, normally noradrenaline. So, excuse me. With and or without vasopressin, the grading system says. So again, this is quite tricky. In the UK, I'm not sure about other countries, but in the UK, for someone to need vasopressin, this is definitely a second line. It means that they're quite sick. So to just have that very vague, and as vague as that, with or without vasopressin, really doesn't answer the question of how sick the patient is. Why is that important? Well, depending on the grading of CRS comes the therapy. So initially, we all give supporting treatments, antipyrexials, paracetamol for the patient. But as they progress to grade 2, then treatment with tocilizumab, which is an IL-6 receptor antagonist, is recommended. And then as they progress to grade 3, and that is why it's very important to know if they're grade 3 or grade 4, apart from the IL-6 inhibitors, then you start to give them steroids and other immunosuppressants like greater doses of methylprednisolone, anakinra, or cetuximab. The second toxicity following CAR T cells, and the reason that they will come to ICU, is this neurotoxicity, or else immune effector cell-associated neurotoxicity. So the pathophysiology behind that is not as clear-cut as CRS. Systemic inflammation seems to be important, but less so than in CRS. IL-6 seems to be more important than IL-1 seems to be more important than IL-6. We have seen pro-inflammatory cytokines in the CSF, in the cerebral fluid, but whether they just cross a blood-brain barrier that somehow it's damaged, or whether the actual CAR T cells engage with cerebral endothelial cells, hence causing neurotoxicity, is not very clear. ICANS So this neurotoxicity occurs a few days following CRS. Sometimes it can follow concurrently. Again, there are stages, and as you can see, the most important thing is how to diagnose it, and we use the I-score. The I-score, you can see on the right of this slide, uses 5 different domains, and depending on the scores you get, then you get the grading. The management of ICANS, again, depends on the grade. The low grade is increased neuromonitoring and anti-epileptics. Here, we don't give IL-6 inhibitors, we don't give tocilizumab, it doesn't cross the blood-brain barrier, but we do start immediately with steroids. 10 milligrams up to QDS is what we use, with, again, higher doses of steroids and other immunomodulation and immunosuppression to follow. So, again, these patients will come to us, and I think you heard from previous speakers that CAR T therapies are the future. So you will see them more and more in your ICUs. They will come because they have CRS or neurotoxicity, because they have seizures, because they are hypotensive. But the difficulties that we will encounter as intensivists is getting a differential diagnosis. So when they will come, they will be hypotensive, they will require some vasopressors, but they're also severely immunocompromised. So the differential diagnosis is very important. Always consider sepsis, especially, as we said, because they're immunocompromised, because the two conditions can occur together, and because what we have found is up to 40% of these patients will have sepsis within the first month. As patients that have higher grades of CRS, so the sicker they are, more the chances of them having concurrent sepsis is higher. So make sure that you keep close monitoring. Empirical antibiotics are paramount, with quick escalation depending on the clinical picture of the patient, and vigorous diagnostics is of the essence. Other considerations. So we did discuss that there is a long turnaround time between the decision to give CAR T cells and the actual infusion of CAR T cells. That means that some patients might progress waiting for the cells. Again, managing expectations is very, very important, because some of them might be quite sick and not able to actually receive the cells. A second problem is that after infusion of the cells, the response is possible. It is obvious several weeks after the infusion. However, the toxicities will occur days or sometimes hours after the therapy. So the decision to initiate or continue treatment becomes difficult, and becomes difficult. We do know, and we are aware, especially those of us that do hemato-oncology and critical care, what is an ICU trial. So an ICU trial is where you actually admit the patient, you give them full treatment, but time limited. You set some time limits. This in CAR T patients doesn't really work, because, as we said, for us to find out whether the therapy has actually worked needs weeks and not just days. So patient and family expectation management is paramount. Open communication between the hematology team that has invested a lot on these patients, along with our teams, and the family and the patient themselves is also very important, as is close collaboration between teams. So to conclude, CAR T therapy is here to stay. More and more options and more diseases come forward every day. Common toxicities are the CRS and the neurotoxicity, and you will see them in your ICU. Treatment for CRS is the IL-6 receptor antagonist, tocilizumab, whereas neurotoxicity, you start with steroids. Higher toxicities should be managed in ICU, and please have a lower threshold of admitting these patients in your ICU. And close collaboration to also both to treat these patients, but also to set treatment limits is paramount. Thank you very much for that. I'm happy to take some questions.